So I'm going to start off not with anything medical. I'm going to start off with a moral argument. And that moral argument is that if you believe in the golden rule, do unto others as you would have them do unto you, then we should have a healthcare system for everybody that you would want for yourself. And so starting with that moral thought in mind, I'm just going to have you kind of retain that. Every major religious tradition, and there's about 20 others too, okay, Jainism, others, everybody's got this. Some version of this, all the major religions. So keep that in mind as you think through what your decision would be about what you want the healthcare system to be like. Because I think that's going to be a key thing that should harken back. Because ultimately, healthcare is about human beings, their suffering, their connections to their family, their friends. And the reason we become doctors is to relieve that suffering. And that suffering can come from a lot of things. It can come from physical illness, but it can also come from the social destruction of a healthcare system that denies care in an unfair way, that costs too much, covers too few. So these are I'll put these up. I mean, it's kind of my worries. Maybe some of these are your worries too. First of all, our costs are out of control. I'll show you the data. It's absurd. It's beyond out of control. If there was another word, I'd make it up. Even though we're spending, as Bernie has said, double, what we end up with are outcomes of care that are mediocre compared to other countries that spend half as much. And I'll show you the data. So it would also be one thing if we were spending twice as much if it was easy to get care and we didn't face all the barriers we face. So our access is deteriorating. Despite the Affordable Care Act, we still have almost 30 million people who have no insurance whatsoever. And we've got more than 40 million people who, if they got seriously ill, would go bankrupt. It's the #1 cause of bankruptcy in America today. That was one of Elizabeth Warren's big things that she looked at, was the fact that healthcare costs were bankrupting Americans at the most ridiculous rate you could possibly think of. And again, we've got on the other side of our politics, we've got Republicans who want to do away with a relatively expensive, incremental, Band-Aid sort of fix, which was the Affordable Care Act. I don't want to demean it too much because it did cover 20 million people. 20 million people is a lot of folks. And I can tell you as a physician working in the center city, it saved lives and it saved money. So there's no question about the Affordable Care Act being beneficial, but it was very expensive. It's kind of like if you had a house with a foundation that's crumbling and you said, let's put a 3rd floor on it. And that's kind of what we did, right? And it's a reasonable 3rd floor, but the foundation is crumbling. And that foundation, as I'll point out here as we go along, is the incredible complexity. It isn't even the profiteering. It's the incredible complexity of the healthcare system through its financing that is really one of the major causes of these barriers. So this would be ordinarily a whole nother hour talk. How the hell did we get here? It often helps you to know how you got to some place because that'll tell you maybe how to get away from that place, right? It can kind of provide you a map. But we have had multiple presidents propose a national health insurance program for the United States of America since Teddy Roosevelt did it in 1912 when he ran on the Bull Moose Party. He had already been over to Europe in a junket after he was president and seen the German healthcare system, which was already up and running. And he came back, and on the Bull Moose Party, he proposed national health insurance as one of his planks. Now, he didn't win. It was a 3-way race, and he ended up losing. But the bottom line on it is those ideas caught fire a little bit in the US, and we had several people come up with proposals to actually have a national health insurance program. But modeling it on Germany in 1914, not a good idea. Now, there was nothing German that was going to be any good in the early 19-teens. So that kind of got put beside. Franklin Roosevelt got talked out of it. The AMA threatened to trash the entire New Deal. And because the AMA, he was good friends with Dr. Morris Fishbein, the president of the AMA. He said, don't do it. You know, you won't get your Social Security, you won't get your disability, you won't get your workers' comp, or all the other, the works projects that he did. Harry Truman actually picked up a bill that was introduced first during the Franklin Roosevelt term, and it was called the Wagner Health Act, and eventually got converted into something called the Wagner-Murray-Dingle Bill. Debbie Dingle, who's in that lineage, she's actually married into that family, is the representative just north of here, north of Toledo. But she's on a bill, again, with a lady named Jayapal to put a national health insurance program in place in the US. Lyndon Johnson actually had success. It was a huge struggle. There's a wonderful discussion of this on the Medicare website about the history of how we got Medicare. If you want to have fun and read about it, it was not an easy deal, but it was a significant deal because it covered old people who insurers did not want to cover. So why do insurers not want to cover old people? They get sick, okay? 5% of people generate 50% of the healthcare costs. If you're an insurer and you can avoid that 5%, you will be rolling in dough. If you take more than your share of that 5%, you will be broke. It's all about avoiding sick people. It's one of the major effects of the Affordable Care Act was to outlaw this idea of pre-existing conditions, which Mr. Trump has now reintroduced in these short-term plans because they don't have to have those restrictions. Nixon actually gets in the middle of this a little bit because healthcare costs were going out of control even in the 70s, and he was told that HMOs were less expensive. So Nixon helped pass the HMO Act, which said that any business with more than 500 people had to have an HMO as part of it. And at that point, we go from Blue Crosses, which are maybe even statewide in most states, and not a whole lot of private insurance competition out there. We go to HMOs, and the complexity explodes because now we've got more and more insurance companies, right? More and more of them with different rules, different copays, different deductibles, all trying to sell to businesses, all trying to do this pre-existing condition thing and avoid the sick. So that's all exploding. We got Bill Clinton who comes in because now we've got almost 40 million people uninsured. And he says, I'm going to run on covering everybody. But Bill was kind of a rube. He was from Arkansas. And he didn't realize that after the president, the second most important people in Washington, D.C. are committee chair people. So he sent his wife Hillary into seclusion with experts, and they came out with a plan and presented it. And the committee chairs had no interest in it, no involvement in it, no stake in it, and it failed. Barack Obama, who's the next man in on this. Now, I have to say that we did get a little something because in the second term, they were smarter. They expanded Medicaid to children. And that really covered, it's called the CHIP program, Children's Health Insurance Program. It did cover a lot of near poor kids. Kind of what the ACA is to adults, the CHIP program was to kids at that time. So it was a significant, but small but incremental step that helped cover more people. Barack came in and he was smarter. He'd been a senator already. He knew who the second most powerful people in Washington were. And he said to the committee chairs, bring me a plan. If you don't, I'll give you one. And of course, they came to him with some interesting plans. We already had a Heritage Foundation idea that was in place in Massachusetts, put there by Romney. And it was actually described in some of the Heritage Foundations. It's a very right-wing think tank. They like marketplaces, right? There's no problem that cannot be solved, by market forces, as far as they're concerned. This one cannot. I'll show you information later on. This is not going to be solved by market forces. But that was up and running in Massachusetts, and people said, well, it's kind of running. It's a much more complicated history. I don't have time to tell you how they got the money together to actually make the Massachusetts thing happen, but it's cute. It's kind of a jujitsu getting federal dollars to Massachusetts. But anyway, it was working, so they kind of adopted that and worked on that, and we ended up with marketplaces and a Medicaid expansion, which is basically what Massachusetts had done and proved worked, and that was the ACA. But the ACA is leaving about 10 million or so people were covered by Medicaid. Another 10 million people were covered by the marketplaces. It still leaves about 30 million people uninsured. And then we got Donald Trump, who tried to repeal and said he would replace, but he had no replacement. And John McCain basically got off his deathbed to vote against repealing the Affordable Care Act. And so we didn't have that happen, but now they're still suing because they canceled the thing that the Supreme Court said was necessary. The Supreme Court said you could tell people they had to buy insurance because it was actually a tax. And there's no question Congress has the right to tax. In the Tax Act, it gave lots of goodies to rich people and corporations that Trump passed in his first few months. They took away the tax. And so now the tax is zero, and they're saying because the tax is zero, the whole law is unconstitutional. And most experts think that's BS, but the bottom line on it is we're going to find out because I think tomorrow They're going to make a decision whether the Supreme Court will hear that case about the Affordable Care Act before the next election or not. So we'll find out. So I think as you can see, we've been kind of chewing on this bone for a century. And that's often true for really hard problems. And toward the end of my talk, I'll talk about hard problems a little bit. But are we going to go incremental again? Or are we going to really try to do something comprehensive? So that's the basic questions that I'm going to outline here. I think the history is important, so I spent extra time on it. So what I want to show you here, and this is the important point, look at this huge drop, right? That's right around World War II. The reason we have health insurance hooked to our job in the US, no other country hooks health insurance to the job. The reason we hook health insurance to the job is because in World War II there were wage controls, but there were not benefit controls, and there was a labor shortage. And so what businesses did to attract labor during World War II when they had a shortage was they gave health insurance. And at the same time right in here, we see the unions really growing, and once they got that health insurance, they liked it, and they began to negotiate, and they've been doing it ever since to hook health insurance to our job. Now, one of the reasons we like health insurance on our job is because it's tax deductible. That happens to be, the tax deductibility of our health insurance is one of the biggest tax subsidies in the entire federal budget. It's like, you know, how they do oil depletion allowances and all these other things, these subsidies. Our health care, by being tax deductible, prevents a whole lot of revenue from coming into the federal government. So basically, it's a tax, if you want to think about it that way. I mean, when it ends up being the fact that we're actually producing less revenue for the federal government as part of it. And that's going to be important because I want to tell you that in the next slide. But right in here is Medicare and Medicaid. And then we kind of start to climb again, and we end up with the Affordable Care Act up in here, and it dips again. And now you can see things are starting to come up again. As a matter of fact, it's been up a couple million in the last several years, partly because of the attacks from the Trump administration on the Affordable Care Act. This is our health spending as a percentage of GDP. The black line is us. This is all the European democracies in places like Australia, New Zealand, Switzerland. Anyway, so here is all them in terms of their percent of GDP they're spending on health. Here's us. Here's where we started. This is 1980. This is right about when that complexity takes off again. It's right about when the HMOs come out and we start to have all this complexity, multiple insurers competing. So the next thing I want to show you here is this is the cost per person. Now this is a little dated. I think this is 2017, and the data always comes out a little bit later. But we're a little higher than this even. But here's what the important point. This is what we're spending in tax dollars plus that subsidy for having our health insurance be tax deductible. So when they don't get the revenues, basically that is something that could be used to pay, right? That money is coming into the economy as health insurance, but if it was just given to you, then you pay taxes on it, we'd be here. This is the public expenditure now in the US. So we're actually paying for national health insurance and not getting it. We might not even have to spend another penny if we wanted to be as frugal and careful as all these other countries. The only country that would exceed us then would be Switzerland in terms of dollars spent per person per year. And that isn't new. That's the way it's been here. So this is kind of the way it breaks out, that right now, privately, we spend, and that's including premiums, about 35% comes from private. The other almost 2/3 comes from tax subsidies, the fact that we pay for, how many public employees here, or people that were public employees? Because when we pay public employees, it's our tax dollars buys private insurance. So again, we're talking about the fact school teachers, the people, the police, the fire, all those folks are public employees. Then you got the VA, you've got public health expenditures, and then Medicare and Medicaid, which are all funded by taxes. So you actually have 2/3 of the money that's being spent now is actually coming out of tax dollars, right? This is the second thing that you guys were all raising hands about, and I don't think you can see it in the back, but I'll tell you what each line is. This is the growth of deductibles, 162% in the last 10 years. This is the growth of premiums, 54% in the last 10 years. This is the growth of wages, 26%, and this is inflation, 20%. People are trading for health care You want to know why your wages are stuck? Look at the top two lines, because we're spending too much on healthcare. And it's almost impossible to expect anything else. Now, I always hear about waiting times. Oh God, we do something like that, we'll all be waiting in line. Well, here's the deal. We're waiting in line now. This is us, US. And you can see that there are a whole bunch of other countries that wait a lot less than we do. And every one of those other countries spends way less than we do. So this business of waiting, now, I'll put that off if you have more questions about wait times, but believe me, if you're really sick in any of those other countries, you get cared for right away. Has anybody been sick in another country and received care? Yeah, this guy lived in another country. Tom, yeah. Again, most people just would never consider it as conceptual that you'd have to worry that you might bankrupt your family by going to see a doctor. It's just not in their psyche at all that that's something that could possibly happen. So it isn't just poor people who get stuck with this stuff too. This is us again, okay, up here. This is cost-related access barriers in the last year by income. This is everybody. This is poor people. 43% of low-income people are facing serious economic barriers. And look at us. We're right at the very top of it. And here's some of the additional data about skipping care. Now, I showed you how the deductibles are going up and up. So people with high deductibles are even more susceptible to this. They're skipping visits when they're sick, 29% of the time. They're skipping their preventive care. They're skipping tests or treatments. They're not getting the medication. And they're not seeing a doctor when they're their usual doctor. They're often going to Doc in the Box and places like that to get care. And that's, if you got a high deductible, way more likely to happen than if you have better coverage. But it's still, even people with better coverage, 10 to 15% of them are not getting the care that they're supposed to get because of cost barriers. And we're the only country that really has serious barriers like this as a percentage. And that's a little older data. This is updated again. If you actually look at this is like 51%, I'll just go to the bottom line here, experienced relying on home remedies rather than seeing a doctor, skipped a dental checkup, boy, a lot of us have done that, postponed needed care, skipped a recommended medication or tests, or had problems getting mental health care because of cost barriers. And if you said in your household, did anybody have any of those? It was 51% of us. That was about, when people put up their hands, it looked like about what I saw, right? Yeah, we've had trouble. It's too expensive. There are cost barriers. And the bottom layer is more important. 13% of them said their condition got worse because they skipped care. What do you think that means about our outcomes? And so here we go again, one more slide. This is those kind of average those other countries. And if you look in the US, the number that are reporting a problem, didn't get a doctor visit again, didn't get a test done, didn't fill a prescription as compared to these other countries on average. And I think, again, the wait time's about equal. That's that last set. And here's some of the additional data about skipping care. Now, I showed you how the deductibles are going up and up. So people with high deductibles are even more susceptible to this. They're skipping visits when they're sick, 29% of the time. They're skipping their preventive care. They're skipping tests or treatments. They're not getting the medication. And they're not seeing a doctor when they're their usual doctor. They're often going to Doc in the Box and places like that to get care. And that's, if you got a high deductible, way more likely to happen than if you have better coverage. But it's still, even people with better coverage, 10 to 15% of them are not getting the care that they're supposed to get because of cost barriers. And we're the only country that really has serious barriers like this as a percentage. And that's a little older data. This is updated again. If you actually look at this is like 51%, I'll just go to the bottom line here, experienced relying on home remedies rather than seeing a doctor, skipped a dental checkup, boy, a lot of us have done that, postponed needed care, skipped a recommended medication or tests, or had problems getting mental health care because of cost barriers. And if you said in your household, did anybody have any of those? It was 51% of us. That was about, when people put up their hands, it looked like about what I saw, right? Yeah, we've had trouble. It's too expensive. There are cost barriers. And the bottom layer is more important. 13% of them said their condition got worse because they skipped care. What do you think that means about our outcomes? And so here we go again, one more slide. This is those kind of average those other countries. And if you look in the US, the number that are reporting a problem, didn't get a doctor visit again, didn't get a test done, didn't fill a prescription as compared to these other countries on average. And I think, again, the wait time's about equal. That's that last set of bars are the wait times where it's 11% each. Now, I'm going to throw immigrants up here because Mr. Trump has made immigrants an issue. Immigrants are generally younger, they're generally healthier, they use less medical care, most of them are working, and they're paying taxes, and they aren't, if they're not a citizen, eligible for other benefits, right? They can't get on Medicaid, they're not eligible for Medicare unless they're citizens. So, and their kids are using even less care. So down here, ER care, very low in terms of the cost per person in the country, and the cost of the kids is pretty small. So they're not really excessively costly, but one of the places that we're worried about is Medicare. We got Americans using about $30 billion a year of Medicare funds, drawing it down, but our immigrants are actually putting tax dollars in. So our immigrants, because they're younger and healthier, they're actually subsidizing the Medicare Trust Fund because everybody has to pay their HICFA taxes even if they'll never be allowed to get on Medicare. Probably a little bit of a sidebar there, but I just think Mr. Trump has forced me to make some comments about that. I'm going to talk a little bit about some key quality indices. We already saw that we have barriers to care that are causing 13% of people to get worse with their health. Our maternal mortality, this is like third world stuff we're doing here. We have ridiculous maternal mortality in this country. And often it's because women show up late for care. Sometimes they've got severe hypertension that's part of their pregnancy that hasn't been managed. Anyway, showing up, you got a breech kid in you, you're showing up in labor and no OB knows you or has done anything throughout your pregnancy. So our maternal mortality is shocking. This is fourfold what's in Australia. Double what's in Canada and the UK. Our infant mortality. This is deaths in that first year of life. 2 times, 3 times the other countries of the world. Again, what does this have to do with the way the system works and how it cares? Does it have to do with poverty? I think it does. Does it have to do with education? I think it does. But it also has to do with our healthcare system. This is a summary statistic, and I think it's one of the best ones. This kind of apples to apples across all these countries. This is, when people don't get care, they're more likely to die. And deaths are a nice hard thing. It's hard to say, did they go in the hospital? Well, maybe they weren't as sick when they went out. You can always do the apples to apples. But deaths are a nice hard ending, right? You know when somebody's dead. So what we got here is mortality that's related to missing care. So this is the potential years of life lost for every 100 people from all treatable causes. So these are things that could be treated. Now, even the Swedes, who do a great job, they make chicken soup out of chicken feathers every day in Sweden and do it well. But they're at 2.6 per 100. We're at almost 5. And that's not new. This is year after year after year after year. So what does that come up to? It comes up to, if you take all the uninsured and you do the multiplication and you look at what the likely outcomes are, these are for individual states, you end up with about 39,000 deaths a year. Year after year after year after year. Think about what it was when it was 50 million uninsured. This is 30 million uninsured. And so now I'm going to start talking about what else we could do and why it's the way it is. Now, I said the disease is complexity. It was the explosion of complexity. So here in the US, we are now just in insurance overhead. This is, I think, from a year or two ago. Let me look. Yeah, it's 2016. So this is even higher. We're almost at $800 per person in America for insurance overhead alone. These other countries all have simplified systems. These guys, the Germans, have about 1,000 insurance companies. They call them sickness funds. But they're all pooled. They all cover the same basic benefits. maybe if you're in one pool versus another, you can get a spa treatment in Baden-Baden or a second pair of glasses. But the actual care, the treatment package, your ability to access care doesn't really differ package to package. They have a public option. Most of these are union-related programs. But you can see, even in a highly complex place like Germany, where at least they pool all the money, they're, what is that, a third, less than a third of what it is in the US. But this goes on over and over and over every year, too. So here we got a guy who is running Centene, which is a big insurance company. These are the CEOs, making $80,000 a day. Thanks, Nancy. A day. I think this is fascinating. Denmark has, what, like 9 million people? They're spending $240 per capita on drugs. We're spending $1,026. This is data from 2015, so we know it's worse. Denmark? Well, we heard about Denmark in the debate last night, right? Anyway, so the bottom line on it is all those other countries negotiate with the drug companies. Because here's the profits, right? And this is from 18, and the 19 ones are probably out, but I haven't seen the numbers yet. So the drug companies are making about $70 billion. The insurers are making about $22 billion. Now, I'm going to just kind of, well, maybe these guys, $4 billion for for-profit providers. That's like for-profit hospitals, large physician groups that are for-profit, that have been marketized, that have been bought by Wall Street. There are large physician groups now that have been purchased and are now, they trade stock in those companies. But anyway, the bottom line on it, this amount and this amount, we don't need those. I mean, we do need drugs. I mean, we need pharmaceutical companies. We need somebody to produce the medicines, right? We need defibrillators and catheters that we use for heart caths and stents and artificial hips and knees. I mean, that's the suppliers. We've got distributors that are giving us Band-Aids and IV poles, and we got pharmacy lab and benefit managers. Again, probably, but that's like chump change, 1.3 billion. So 22 billion, what are we spending per year? 3,600 billion. 3.6 trillion every year. That's what we're currently spending in the US on healthcare. 3,600 billion. In order to make these guys happy with their 22 billion. Now again, I'm not king, but I would do a Godfather offer. You can take 22 billion a year and go away and find something better to do and let us have a healthcare system. Because that would save us so much money to just go to the simplicity of Medicare for all. So I'm going to start talking about that idea. So here we are. This is, they call it a grand experiment. This is the HMO Act and the explosion of complexity. This is the Canadians. Exact same time we were doing HMOs, they decided they were going to they were doing it province by province, they were going to complete their national health insurance program. And it's not, everybody has the same program in each province. That, in a sense, is complex. They don't have one program for everybody in the country. But you can see basically what happened to their costs. Much flatter, much greater savings in the Canadians. Now, there were times where it even went down. And during those times, people actually got a little grouchy because there was probably too tight a control on healthcare. And so at that time, there were probably lines in Canada for heart services and things like that. I have some nice stories from one of the guys who ran Ontario's waiting list for cardiology services. So if you got big questions about lines, I can tell you. The Canadians realized that you don't let doctors control lines. That's a really bad idea. And all they had to do to really shorten their lines in Canada dramatically was leave holes in them. So that if somebody, say, had angina, chest pain with heart disease and was supposed to get a heart cath or have bypass surgery, if you leave holes and they get worse, you can move them up. If you don't leave holes, then you have to move that person to the head of the line and everybody else moves back. So all they did is realize we just need to leave holes in the line, and the lines went in half. So they should have gone to Cedar Point. Maybe Cedar Point should try that, I don't know. So, explosion of complexity. Same date, guys. Here we are, 1980. Explosion of complexity. That's the growth in non-clinical personnel in healthcare. This is the growth in physicians. And if I put nurses up there, it's below the physicians. This is a jobs program for paper pushers and money changers that won't quit. And it's like, you'd think it might slow down, right? It's just worse and worse and worse and worse. And all of this is representative of the complexity of 1,000 different insurers, each of whom might have 5 or 6 different plans with different networks and different co-payments and different deductibles. And every one of those insurers, their complexity reflects into our offices as physicians. So we have to be able to cope with the complexity, and so do the hospitals. And so we have to hire an army of people to fight with the army of people that the insurers have hired, right? So we got 3 armies of people in doctors' offices, in hospitals, and in the insurance industry. So if you look at overall administrative costs, not just insurance administrative costs, we're spending $3,300. That's just a little bit less than England spends per person for their entire National Health Service. It's like $4.5 grand. And here's Canada with its simple, basically, they call their system Medicare, Medicare for all, at $745. So hanging out there, if we simplify, is what? $2,500 per person on 330 million people? It's a lot of money. So the common financial models, you got National Health Services, that's the doctors and nurses and hospitals are all owned by the government, run by the government. You're a government employee, kind of like being a cop or being a fireman. You've got National Health Insurance, which is what we do with Medicare, and Australia, Canada, Ireland, and Spain, and who's off there? Taiwan is the most recent one, are all doing a single payer equivalent of Medicare for all. And then you've got the Bismarckian system. It's called Bismarckian because he was the guy that put the German system in there before Teddy Roosevelt came around, where you had all the private insurers completely looped together into a single pool, negotiating together with the drug companies, negotiating together with the doctors, negotiating rates with the hospitals. And most of those other countries actually pay hospitals by budgeting them, but we'll talk about that as part of our solution. And if you do a mixed funding with no regulation, you end up with a lot of people uninsured. In this particular case, in the US, about 10, 11 million people uninsured. So there's the facts there. So right now, in the I don't know how many of you are trying to pick a Democratic candidate versus thinking you'll stick with Mr. Trump, but we'll talk a little bit about what we might expect with Mr. Trump too. But basically, it's breaking down into maybe 2 camps. One is, let's take Obamacare and try to restore it, because it's been chopped at a little bit, and add a Medicare-like public option. That's Mr. Buttigieg, Medicare for all that want it, right? And on that same bandwagon, or Mr. Biden would say that Buttigieg stole it from him. But anyway, we got Biden and Buttigieg, Klobuchar, Steyer, Bloomberg, all kind of in that. Now Warren has said that she wants to get going right away, and since the Affordable Care Act already exists, she wants to go ahead and jump on that bandwagon at least initially, and work on Medicare for all later on. And even Buttigieg, if you read his white paper that's on his website, calls his program a glide path to Medicare for all, because he thinks if we do the right kind of public option, everybody will choose it. So it could take a while. And then there's other lawmakers, and Klobuchar is on this bill, that say, let's just fix the 50 to 64-year-olds. They're in the worst shape, and just let them buy into Medicare early, but then you're buying in, and you have all the complexity that's been added to Medicare, in particular the Medicare Advantage plans, which have markedly increased the complexity of Medicare. And then you got Bernie, basically, with Warren kind of half on, which is to say, let's do a single payer, let's do an improved Medicare for all. We've got bills. Sanders wrote the damn one, and Jayapal wrote one that I guess isn't damn. I haven't heard her use that word. So we've got 2 bills, one in the House, one in the Senate, both of who have been looked at and actually studied. Now this slide's a little light, and it's probably too wordy, so I'm just going to summarize. Basically, if we do an improved expanded Medicare for all on this side, we've actually got really good evaluations of what that's going to cost. So I don't know why Bernie won't just say it. because we've got really good evaluations of what that's going to cost. And it's going to cost less than we're spending now. Now, the problem is that public payment is only 2/3 of what we'd like to spend in order to spend what we're spending now. So we've got to come, so that's about $2 trillion. We've got to come up with another $1 trillion, given what we're going to save with Medicare for All, and I'll show you some numbers in a second on that. And over here, we just don't know. Basically, Buttigieg, in his white paper, says that doing a really good public option is going to cost us $150 billion or $1.5 trillion over the next 10 years to do a really good public option. And everything else stays the same. So we're talking about adding $150 billion to the existing $3.6 trillion. So what's that? Now we're $3.75 trillion.
How much would the public option plan cost per year approximately?
He's saying about $150 billion per year.
For me, if I buy it.
He hasn't said that at all. Yeah, I mean, I don't know whether they're going to scale that. You're young, you're healthy, or I don't know how they're going to scale it, or whether it'll be a. Yeah, there's some community rating means everybody in the community pays the same, and Bob here is saying, yeah, probably community rated, but I don't think he knows. I don't think he knows. So it sounds great. You'd let people under 65 buy into Medicare, and some plans would let employers offer Medicare instead of their employer plan, so they would hand their money over to the employer, to Medicare, and say, take care of our people. And again, nobody knows quite what that would look like. But it has this sort of free market choice. I think it's a false choice. So if I told you that you could have choice of insurer or choice of doctor and hospital, what would be the vote? Would you want choice of insurer or choice of doctor and hospital, given you would spend the same amount of money? I mean, this is just a false, this is like a whole false mean. What we really want when we want choice is to be able to see our doctor, the one we trust the most, or go to one that we need, and if we need to go to Cleveland Clinic or Mayo or whatever, we should be free to go, which you are in traditional Medicare at this time. Again, so you got this sort of free market appeal to buying in, blah, blah, all this sort of market language. But in all honesty, what are you buying into, right? That's the question. And it's because it sounds capitalistic, it's kind of an easier lift, maybe, but not really. Because here's what our problem is. We're going to miss the savings, the administrative savings. Because if you leave everything else there, then all that administrative waste I was showing you is still there. And you've just added one more layer, which is kind of what Obamacare did. It took that house with a crumbling foundation and put a 3rd floor on it. So now we're talking about putting a 4th floor on a house with a crumbling foundation by doing a public option. So we don't get the savings. And it relies on premiums, which, this is one of the things most people don't understand about premiums, is they're totally unfair. When I was working at St. V's at about $200,000, my family's policy was $20,000 a year. The woman who kept me on schedule, who was making $25,000 a year, her family policy was $20,000 a year. Now, if you did that as a percentage of income, it's 10% of mine. It's almost half of hers. I mean, this is totally upside down. It's a totally regressive way to fund. So the CEO, Mr. Not quite smiling, making, what was he making? $377,000 a day. His secretary is getting the same benefit that he is. I mean, so this is really very upside down in terms of how we're financing it as a percentage of your income. So premiums are totally regressive in that way. And it's not really going to do much for the uninsured. And one of the things they're talking about is these poor insurers, right? They're really worried about getting all these sick people, right? So they want to do these things called high-risk pools. They put them in at the beginning of Obamacare. They disappeared like overnight, probably all into the pockets of the insurance companies. But it says if you spend more than, say, pick a number, $100,000 on this sick person, then the public will pick up the cost from that point on. I mean, so they want to stick us with the sickest, most difficult ones, and it's just like guaranteeing the insurance company profits. I'm sorry, I'm not sure they're worth it. So this is an old slide. I haven't seen an updated one, but you can look at the proportions. This is our current system. If you say at this particular time, administrative costs at this point in time were about $673 per capita. The public option that was contemplated during, because we built this slide during Obamacare when the public option was being proposed, We guessed it would, by doing a good economic analysis, that it might save, and it's mainly in insurance overheads, maybe 10%. If we do a single payer, boom, look at how that insurance administration drops. Our current Medicare spends 2 cents. The average for most big insurers is 12 cents on the dollar. Some of these smaller insurers, it's 20 cents on the dollar or more. Before Obamacare, there was one, it was called Golden Rule. Since I talked about Golden Rule, it was out of Indiana. 50%, they kept half the money. They were selling individual policies, and they kept half the money for their own uses. So if we go to a single payer, there's the savings we need to cover 30 million people. It's right there. I don't know if we'll keep the ACA, but it'll certainly be meaner, and it'll be rebranded as Trump Care or something if we do get to keep it. And they'll find a less progressive way to fund it. They're going to probably attack Medicaid again and make it, something where work rules and all these other things that they're talking about that just get in the way of people. We actually studied work rules in Ohio, and they found out that giving Medicaid to people helps them work. They actually are healthy enough to go to work. And it was all these upside down ideas. And again, we've got privatization all over the place. I mean, and these are all, I won't list them all, but these are all the market forces things we've tried, right? HMOs and privatization of hospitals and insurers and insurance exchanges and markets across state lines and HMOs and managed care and capitation and HSAs, what is the HSAs, health savings accounts and high deductible plans, association health plan, bundle payment, pay for performance, ACOs, Cadillac tax, high risk pools, and my God, the holy grail for doctors, malpractice reforms. And guess what? Our costs are still double everybody else's. The market isn't working. It never will. It never will because it isn't a normal product. That's why you don't want 2 surgeries when they're on sale. And all it does is it raises costs and it kills people. I won't say much more about that slide. And I'm not going to talk about Medicare Advantage. It's a ripoff too. Because everybody will be covered. When they go to the doctor, they won't have to worry about the cost of it. They can choose their doctor and choose their hospital. Now, if they would rather than choose their doctor and choose their hospital and would rather pay a lot of money when they go, then I guess we're not giving them the choice they want. But I don't know what kind of a person would want to make that choice. And G, what's the G word? Government. I'm the government. I'm here to help you. I mean, I drove here on a road we built together. When I went to the bathroom before I started talking, the pee went away when I flushed. We did that together. I had a drink of water from the fountain. We did that together, although in Toledo, that could be dicey. Here's the real question, guys. This is Frederick Douglass. Are we going to fight for it? Are we just going to lay there and take it? Or are we going to fight for it? That's the question. Our votes still matter. Now, if we'll use them, if we get somebody who doesn't want our votes to count out of office, because I'm going to vote for whoever comes out of this, that'll get that guy out, because he's a threat to the planet. Right? He's also a threat to every one of us and every one of our children and every one of our husbands and wives and friends and family. But, man, he's a threat to the planet, too. So I'm here not because I'm a Bernie supporter. I'm here because I'm an expert on content. And I'm trying to tell you that other countries have done this as recently as the 1990s, Taiwan to be exact. This is not something that hasn't been tried. Public option, built onto what we got, never been tried. Medicare, how it works, we know how that works. We've done it. It's kind of working now. It's been working since 1965.